I'm Paul Barr from the University of Rochester and from the 2017 ASCO annual meeting. I gave a talk on the World Health Organization classification system for lymphomas. There was a 2016 update to the WHO classification. So the purpose of this talk was to update the classification system for pathologists, for community oncologists, and in thinking about these changes, how to apply them to clinical trials going forward. From a clinician's perspective, I do think, as complex as it is, we do have to be cognizant of the changes that occurred in the 2016 update, because they do change how we think about treating lymphoma. And I think the first point to make clear is that we're now dicing up lymphoma into nearly 100 different entities, so it's complex. All the more reason we have to have a very good relationship with our pathology colleagues. We have to be able to discuss the clinical presentation so that we can arrive at the right diagnosis. I think that just makes common sense. In addition, the most pertinent changes were applicable to the aggressive B-cell lymphomas. So we now divide up diffuse large B-cell lymphoma. It used to be one entity. It's now required to define whether it's of germinal center B-cell subtype or ABC subtype. And furthermore, we have new diagnoses: high-grade B-cell lymphoma not otherwise specified, and high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 translocations, the double or triple hit category. So as a clinician getting that pathology report, we're going to get new information and we have to know what to do about it. And I think very much to the point, in short, our standard of care for most patients with diffuse large B-cell lymphoma is unchanged. R-CHOP-based therapy still cures around 60% of diffuse large B-cell lymphoma. But as we learn in clinical trials how to treat these subtypes more specifically, things will change. And I think the one place where it has, for the double hit patients that have a very poor prognosis, I think at this point we should consider dose-intensive therapy. The dose-adjusted EPOCH-R regimen has demonstrated in a phase 2 trial potentially improved outcomes. So that's the one place I would consider using EPOCH over R-CHOP. And given the risk of CNS dissemination, I likely would consider methotrexate-based prophylaxis for those double-hit patients too. But I think another take-home point is we have to watch this going forward. It's going to continue to change. So again, all the more reason to have a very close working relationship with our pathologists.